Assalamu alaikum, good morning. Thanks to the GIS for the invitation, and what a great introduction to the session and a beautiful conducted live case, I think, which was with a low calcium. So it's I have nothing to disclose in relation to this talk. The whole concept of TAVR when it started was around having a calcified valve. We learned over time about the anchoring, oversizing ratio, sealing, all those terms we learned over the last 15 years, and then subsequently secure deployment. But of note, there is no specific calcium requirement for any of the pivotal trials. The initial trials were done by the transesophageal echo as a guiding modality for sizing, and subsequently you were not asked to do a CT scan specifically to look at calcium. You look at the CT scan and you assume there is enough calcium to anchor the valve. We start to learn about calcium as we go on in our TAVR journey. We learned a lot about high calcium, but if you remember, the talk is about low calcium. So let's start with the high calcium. High calcium has been associated with worse outcomes, including paravalvular leak, pacemaker, aortic valve injury in certain platform, and deformity in the valve, especially in the self-expanding platform. In this trial, in the graph in the right hand of the slide, you can see that there is a proportional increase in the significance of a paravalvular leak that increases with the amount of the aortic valve calcification. Subsequently, there are multiple trials. This is recently published, specifically looking at if we classify a patient according to a tertile of calcium in the aortic valve. Patient who went for TAVR, they went back and looked at the amount of calcification. Patient at the lowest tertile suffered the least amount of post-procedural complication related to pacemaker or paravalvular leak compared to the patient in the highest tertile. But when you look at their 12-month outcome in terms of mortality, there was no difference in heart outcome between high and low calcium. Early on in the experience with self-expanding valve, if you remember, this trial was more than almost 10 years ago. The investigator looked around 100 cases, patients who were or who encountered valve dislodgement during the procedure, and they looked back at their CT scan, and patients who had a CT score less than 2300 was one of the strongest predictor of having a valve dislodgement related to the self-expanding valve. So now as a TAVR operator, you get the TAVR report from whatever platform, and you look at the calcium score. Truthfully, we look at the calcium because we are looking for a high calcium to help us with the procedure. But let's dig deeper a little bit in where did the data driven from the calcium score. Early in the 1990s, this is when we started to do calcium scoring of the aortic valve, specifically in cases where there is discordant between the aortic valve stenosis and the echo finding. So around 40% of the patients which we see in our clinical practice has severe aortic stenosis, yet they don't have the hemodynamic parameters in echo that justify or that confirm the aortic stenosis. Aortic valve calcification came as a clear differentiating modality to help us as operators to define severe calcification, and I will go over the specific number. But there is a caveat here. The aortic valve calcification has to be done with a non-contrast enhanced CT scan. Most of the modality that use non-contrast enhanced CT scan is the one that we derive all the current data in terms of the amount of calcium to define severe ES. There's a clear correlation. The Agostone score is derived from diastolic measurement of the aortic valve calcification in 60 to 80% of the RR cycle. The slide thickness is 3 millimeter. It's a semi-quantitative method, which means there is a software, but there's another operator, which is the radiologist or a CT cardiologist, who's able to define if the computer did a mistake. I give an example here of a case that is published in this report where a patient had a severe low gradient aortic stenosis with a low stroke volume. The CT scan was done, but if you look at the CT scan, the software can capture the mitral annular calcification unless you correct it. It can capture aortic calcification in the sinotubular junction or the coronary arteries, and as such, It's semi-quantitative because there is an operator who would verify. So the guidelines, the European guidelines, came with the number of more than 1,300 A unit, which is, some people call it arbitrary unit or Augustin unit for women, or more than 2,000 for men, to correlate or to say this is most likely a severe aortic stenosis. So the inter and intra observer variability, when you use this protocol, is very good. The calcium can be a very reliable method to tell you this is severe aortic stenosis. So the current agreed upon guidelines is for women more than 300 and for men more than 2,000. But if you look, there is already a difference between men and women for the severe degree of aortic stenosis in terms of the number. And that's where also they went and added another measure, which is the calcium or the aortic valve density, where you calculate the aortic valve calcification and divide it by the aortic valve area. And the number that is in the guidelines, more than 300 for women and more than 500 for men. So all what I have shown you so far is calcium with or aortic stenosis with high calcification. So where am I in this talk where there is TAVI with low calcification? Okay, so let's go further and let's look at our population. Probably all of you, including the last case which has been transmitted, has a low calcium with severe low gradient aortic stenosis. So does the value of the aortic calcification apply to our population? We have not seen any validation within our region in the Middle East. But in this trial, they validated the aortic calcification score in relation to Asian population. This is from 7 international registry within the Far East, Japan, Singapore. And what came out of this study is definitely there is a good correlation for men. But with women, you have to be careful because aortic valve calcification, not talking about the Middle East, Far East, clearly does not correlate as well. The only measure that correlates well with the severity is when you calculate aortic valve calcification density. So if you are going to use it, make sure you look at the aortic valve density where you quantify the aortic valve calcium and divide it by the area. So let's start with the cases, and let me ask myself and you who are doing TAVI, how much calcium do I need in order to do TAVI? If you see a if you see a valve that has low calcium, should you just shy away? So the first thing you are to ask yourself, does the patient have severe aortic stenosis with echocardiogram? And for this patient, she does have severe aortic stenosis by echo. But if you look at her calcium density, it's 264, and by guidelines criteria, definitely she does not fall within the aortic valve stenosis. So this patient, as planned, there is no calcification, but she has severe AS. Let's not pre-dilate. Let's go and do a balloon expandable valve, and we assume the valve in the nominal volume will inflate nicely. As you can see here, we deploy the valve, and there is a constraint in the valve, and we have to add another 2 cc to the pre-existing volume in order to reach the proper valve expansion. This is a case where there is no much calcification. So there's got to be an explanation which we're going to come to in the next couple of slides. Now this is a second case where again there is severe aortic stenosis, again in a woman where she does have less calcification. We chose a different self-expanding platform. We had a good result despite the fact that her calcium density is less than 300. So we are seeing those cases where there is significant severe aortic stenosis, symptomatic, but there is no matching calcification. So this is a case from I found in the literature. I think it also presented in the Japan PCR. Very beautiful case, bicuspid aortic valve with minimal, if any, calcification with severe aortic stenosis. This speaks to the challenge that we see in those situations where the operator tried to use or tried to match the sizing of an uncalcified aortic stenosis to the usual calcified platform that we are used to. He used a 23 millimeter self-expanding valve based on the annulus. It did not anchor, so he ended up using or oversizing significantly with a 26 millimeter valve, 26 millimeter self-expanding valve. So is there any pathophysiological explanation for this phenomena? This is a beautifully conducted study published almost 3 years ago. It matched both explant valve from surgery with also similar patient that had CT scan. They classified the patient into young and old bicuspid and tricuspid, male and female young being less than 60, old being more than 60. And they match them in relation to chronic kidney disease, blood pressure, in order to find a good propensity matching. What is more interesting, if you look at the right side of the screen, for all young bicuspid, tricuspid, woman has more fibrosis in this slide and more collagen, which is reflected in red in this stain, compared to men. So for all young bicuspid and tricuspid, female has less calcification, more fibrosis, and despite having a similar degree of aortic stenosis. So that's another glimpse of the difference between women and men in relation to the degree of calcification. And if you look at for within the same study, if you look at the difference in the mean gradient, there was no statistical difference between the mean gradient between men and women. But when you look at the aortic valve calcification density differently, there's a more difference favoring men over women, meaning less calcium. But if you look here, how much connective tissue and how much collagen matrix, definitely woman has more fibrosis than calcification, and those are the cases that probably we are doing TAVI in low calcium. So they do exist. Now let's switch gear and see where are we asked to do TAVI with no calcification. This is more practical in patients who have pure aortic insufficiency. I'm going to take a couple of minutes to talk about this. So definitely worse outcome compared to severe aortic stenosis, a lot of migration. But there is hope. If you look at the data in the initial reports, the success of the device was very small. Then they compare, if you look at self-expanding in the TVT registry, clearly worse outcome if you do it for pure AI compared to S, a lot of embolization and higher all-cause mortality. If you compare old generation versus new generation, when you do it for pure AI with no calcification, definitely newer generation with the improvement in the skirt has did a little bit better, but definitely not even close to the outcome we are getting with severe AS. Is there any specific platform that we might bank on in the future for those cases? I think I need 3 minutes because I started 3 minutes less.
3 minutes for the presenter, please.
So this is a publication
Slides
from sorry, if you give me the control of my slide. Thank you. This is in pure aortic insufficiency using the MI valve. More than 113 cases basically. But what came out of this study is a neat concept that if you are going to do this in somebody with pure AI, look at the relationship between the alveolar flow tract and the annulus. If you remember from the case, the live case, we were looking at the 4 millimeter above the annulus. Here we want to look at the alveolar flow tract in relation to the annulus. If you have the tapered one, it has been associated with the highest risk of embolization. More importantly, the oversize ratio for a balloon expandable valve in this trial was almost 18%, and in some cases reaching 25% in order to match that. And despite that, the outcome was not as comparable, significant paravalvular leak, and also second valve needed. So this is a neat case published in JACC, where they are doing TAVI in LVAD. This is a niche that you're going to do or you're going to see in the future for certain centers which deal with TAVI. AI is a significant complication for patients with prolonged LVAD. This is a nice case where they've done a special platform. This form is currently, or soon will be approved for this indication, which is pure AI, the Yana valve. And basically they end up with a great result despite the lack of calcium. From this case, I'm just going to take you to talk briefly about TAVR and LVAD. For certain centers, this is going to be reality in the future. Again, frequent complication, more need for a special platform. The Yana valve will be someone that we could do in the future. This is the trial for the Yana valve published in TCT. This is not the trial, the Cardiology. This is actually the European experience, pure AI. Good result in terms of paravalvular leak, 98% success rate for this device for AI with 0% moderate paravalvular leak. So I was planning to read my conclusion, but I could tell you for a time being, we are doing TAVI with low calcium, most likely in women. Take attention to the sizing. The platform currently, there is no special platform better than the other, with the exception of the NA valve that is currently being used for pure AI. Thank you.
Thank you.